going to meet for 2 hours to hear from witnesses on our study of Canada's health workforce. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021, per the directive of the Board of Internal Economy of March 10, 2022. All those attending the meeting in person must wear a mask, except for members who are at their place during proceedings. I believe most, if not all, of the witnesses with us today have been with us before, but just a couple of reminders, if I could. Please wait until I recognize you by name before speaking, and just click on your microphone icon to activate your mic, and please mute yourself when you're not speaking. You will see on your screen that you have the choice at the bottom of the screen of either floor, English, or French. And another reminder that please do not take screenshots or pictures of your screen. Everything we're doing here will be made available via the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. I would like now to welcome the witnesses who are with us this afternoon for 2 hours. From the Canadian Medical Association, Dr. Catherine Smart, President. From the Canadian Nurses Association, Tim Guest, Chief Executive Officer. And from the College of Family Physicians of Canada, Dr. Brady Bouchard, President, and Dr. Francine Lemire, Executive Director and CEO. Thank you all for taking the time to appear today. I know for some of you it isn't your first time, but there was a will among many committee members to have a further discussion on the roadmap work that you are undertaking. Not that the questions will be limited to the roadmap, but that's the reason for calling some of you back. We will now proceed with those questions. We will now proceed with opening remarks, beginning with you, Dr. Smart, for the next 5 minutes. Thanks for being with us.
Thank you. I'm Dr. Catherine Smart, President of the Canadian Medical Association and a pediatrician based in the Yukon. I'm speaking to you today from the traditional territory of the Kwanlin Dun First Nation and the Ton-Quechin Council. Thank you for this opportunity to address once again the growing health human resource emergency. This discussion remains critical. Canada's health workforce is weathering a storm longer and fiercer than any in collective memory. Health workers are still depleted, distressed, and leaving the profession. I'm so pleased to see my fellow health worker leaders appearing here today, the College of Family Physicians of Canada and the Canadian Nurses Association. We are unified in the belief that there is no healthcare system without healthcare workers. We come to you today with solutions, transformational ideas, and reminders of existing commitments that can mitigate the current HHR crisis, address backlogs, expand access to primary care, attend to mental and digital health, and improve virtual care and data. First, bring in retention incentives for health workers to improve healthcare access in areas of need. Healthcare workers in underserved communities and particular care settings are burned out and exiting their career, creating serious resource constraints. Current commitments to incentives are a start, but more needs to be done. 2, release the pressure of administrative burdens that healthcare workers face. Heavy workload compounded by administrative burdens is often the kindling to provider burnout and worsening mental health. A commitment of $300 million over 3 years through a federal fund could support jurisdictions to improve the well-being of healthcare workers through administrative and mental health supports in primary and secondary care settings. And it is time to scale up collaborative interprofessional primary care. Too few Canadians can access primary care when it's needed. It's time the federal government delivers on the $3.2 billion commitment to increase patient access to family doctors and primary care teams. Primary care reform is health system innovation that would move us from illness treatment to a focus on keeping Canadians well and out of emergency departments, and move us from fee-for-service payment structures to blended or capitation payment models, allowing for more in-depth consultations instead of incentivizing short visits, which may be insufficient to address complex patient needs. So many of the challenges with Canada's healthcare systems, from funding to efficiencies to patient outcomes, can be solved under one umbrella in concert with a team-based interprofessional primary care model. Designed around the patient journey, primary care allows Canadians and their families to navigate the myriad of health services when and where they need. Imagine. Add to that an investment of $400 million over 4 years can expand the government's existing work through the FPT Digital Care Virtual Care Table. The pandemic created an almost overnight digital health revolution, with Canadians accessing care virtually. It cannot replace in-person care, but it has its place. The CMA strongly urges the government to initiate a parliamentary review on the regulatory barriers to the mobility and deployment of Canada's health workforce under the Canadian Free Trade Agreement. The current regulatory licensing frameworks have to move to a pan-Canadian licensure model, allowing health professionals to work where they would like and where the needs are the greatest. Chair, we cannot discuss the HHR crisis without addressing the mental health of health workers. Long-term sustainable supports are needed now. Through the $4.5 billion election promise and targeted mental health funding, we recommend the creation of a pan-Canadian mental health strategy for healthcare workers, modeled on the federal government's 2019 action plan to support the mental wellness of Canada's public safety personnel. And finally, let's talk about data. Canada cannot plan for our workforce supply needs or distribution if we do not appropriately collect data. With an investment of $50 million over 4 years, we can enhance health workforce data standardization and collection processes across PTs and establish a center of excellence through an existing agency to centrally house the data and uphold jurisdictional planning efforts. This innovative thinking presented today puts people at the very center of the solution, ensuring that current and future generations of healthcare workers have the supports they need to join and remain in their profession. There is a duty to address the emergency before us immediately. From there, we can look forward to long-term integrated health human resource planning. We have to care for those who care for Canadians. I look forward to hearing from my health leader colleagues on the realities facing the nurses and family physicians they represent. Thank you.
Thank you, Dr. Smart. Next, we're going to hear from the Canadian Nurses Association through their Chief Executive Officer, Mr. Guest. You have the floor for the next 5 minutes.
Thank you, Mr. Chair and members of the committee. As you know, my name is Tim Guest. I am a registered nurse, and I'm the Chief Executive Officer of the Canadian Nurses Association. I want to acknowledge today that I am speaking to you from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. The Canadian Nurses Association is grateful for the opportunity of appearing again on this important study alongside our colleagues, the Canadian Medical Association and the College of Family Physicians of Canada. We continue to hope that the committee's work leads to meaningful and much-needed action to address Canada's health workforce crisis. I'd like to first recognize that today marks a very special occasion as we start National Nursing Week and Indigenous Nurses Day. This week, we recognize the important contribution of nurses. Their knowledge, expertise, leadership, and compassionate care are an inspiration to us all as they continue to answer the call despite the crisis they face. Nurses and healthcare workers are at a breaking point. This is an urgent national issue, and pan-Canadian collaboration is needed to address this multifaceted crisis. CNA is grateful for the opportunity of collaborating with the Canadian Medical Association and the College of Family Physicians of Canada in developing a roadmap of solutions. I wanted to highlight 3 key elements from that roadmap for you today. First, this is a crisis of retention more than recruitment. In the short term, we need to stop the bleeding and help keep nurses and healthcare workers in their jobs. Canada needs to implement retention strategies and improve their well-being. If no effective strategies are put in place to retain nurses that we have now, no other strategy will make the difference. Nurses need mental health supports, and their workloads need to be reasonable to make sure they will stay. Funding for retention bonuses for late career nurses and federal income tax relief for healthcare workers can also help. Also, student loan forgiveness shouldn't be exclusive for those practicing in rural and remote areas, as we are also seeing shortages in urban centers. Hiring more cleaning or support staff can also be effective to allow nurses more time to provide nursing care. Secondly, in the medium term, we need to increase system capacity for educating and training of healthcare workers, as well as accelerate the licensing and employment of internationally educated healthcare workers. Internationally educated nurses, or IENs, report great difficulty in practicing in Canada. Barriers include immigration status, long processing times, and registration costs. Targeted federal funding could help increase resources for regulatory bodies. Funding could also help offset licensing costs for IENs. Although IENs already living in Canada should be part of addressing the crisis, they are not a quick fix solution. CNA also urges caution on the recruitment of IENs currently living in other countries due to the global shortages of nurses. A special focus on ethical recruitment is important. Finally, in the long term, Canada needs to urgently improve workforce mobility and data collection, as well as establish a dedicated mental health strategy for healthcare workers to ensure they are supported during crises. As a female-dominated profession, nurses are often care providers for their children and family, in addition to experiencing burnout at work. However, access to mental health supports is lacking, especially in comparison to other public sector jobs, including male-dominated professions such as fire and police services. For example, in 2019, the federal government launched an action plan to help address mental wellness of public safety officers. Furthermore, we agree with our colleagues from the Canadian Medical Association and the College of Family Physicians of Canada on the importance of scaling up primary care in Canada and the need for further supports for primary care practitioners, including physicians and nurses. We need to strengthen patient-partnered care and respond to the evolving needs of the population by advancing primary care through an interprofessional approach. In conclusion, when it comes to looking at how we provide better health care in Canada, we need to look first at our health workforce. They are the backbone of the Canadian healthcare system. They make everything else work. Retaining and caring for them is at the heart of resolving many of the challenges that our healthcare system faces. Thank you, Mr. Chair, and I'll be happy to take questions.
Thank you very much, Mr. Guest. And finally, we're going to hear from the College of Family Physicians of Canada. Dr. Brady Bouchard, President, welcome to the committee. You have the floor.
Thank you. Mr. Chair and members of the committee, thank you for inviting us back to speak with you again so soon after recently meeting on April 4th. This reinforces to us the committee's interest in the acute crisis facing Canada's health workforce. My thanks also to my CMA and CNA colleagues for working together with the CFPC in a spirit of collaboration on an issue that is truly important to the well-being of Canadians. My name is Brady Bouchard, and I'm a family physician and the president of the College of Family Physicians of Canada, and I'm joining you today from Treaty 6 territory and the homeland of the Métis. I'm joined by Dr. Francine Lemire, Executive Director and CEO of the CFPC. Francine delivered our remarks at the earlier meeting, and I will speak today and present in English. We will be pleased to respond to questions in both official languages. We appreciate the committee's interest in the roadmap document that we developed with our colleagues at the CMA and CNA, and appreciate the summary provided by the previous speakers. This document is more relevant than ever. Over the last week, there were several high-profile articles noting the alarming trends in filling family medicine residency positions. The 2022 Canadian Residency Matching Service match data continues the slow but steady increase in unfilled family medicine residency spots. Now is the time to address the root causes of that to ensure long-term sustainability. CARMS matches the approximately 6,000 medical trainees to the training programs for different medical specialties. 1,569 family medicine residency positions were available in the 2022 match. 225 of those are currently unfilled after the first round, 14%. This number has never been higher. As a practicing family physician still in the relatively early stages of my career, I can tell you that family medicine is a fantastic specialty, but these numbers don't lie. There are increasing pressures on our specialty right now that are making it less attractive to medical students. Practicing physicians are reporting record levels of stress and burnout, and some are beginning to retire early, reduce their clinical commitments, or leave the profession altogether. With a cohort of new graduates set to be reduced, the potential future implications are significant. This should be a concern to everyone in Canada because of the fundamental role that family doctors fill in our healthcare system. The roadmap developed with the CMA and the CNA provides a series of actions that can be taken to reinforce our health workforce. The CFPC supports these recommendations and stands behind this pragmatic and actionable plan that will support Canadian family medicine and health care in general. But for that to be true, the plan needs to be carried out. From the perspective of family medicine, there are two areas of focus in the roadmap to focus on. The first are the recommendations in support of currently practicing family doctors. Our members have highlighted for us that the number one issue that would make a difference right now is to reduce the administrative burden that they are carrying. That means reducing the amount of time and energy they are spending on things like general clinic administration, record keeping, and paperwork that take away from direct patient care. Letting family doctors do what they do best, caring for their patients and coordinating care, will help reduce burnout, increase satisfaction, and retain our practicing docs. The second, made obvious by my comments about CARMS, is about changing the practice model of family medicine in the long term so that the specialty again becomes an attractive first choice for our doctors of the future. Newly graduating medical students want to work in teams where their skills are put to best use and they have the resources they need to care for their patients, but are also able to find that work-life balance that is sorely lacking for so many of us. This is why the CFPC strongly supports the recommendation to adopt a primary care integration fund, which will allow practices across Canada to evolve into high-functioning collaborative teams, and in turn improve access to care for all in Canada. Progress on this front has been made, but we need to see a standardized, well-supported approach that leaves no province, territory, or community behind. We look forward to the upcoming question and answer section of this meeting. Thank you again for your time and interest.
Thank you very much, Dr. Bouchard. And we're going to move right to those questions and answers now, beginning with the Conservatives, Dr. Ellis, for 6 minutes, please. You have the floor, Dr. Ellis.
Thank you, Mr. Chair, and thanks to all the witnesses for returning, and my apologies for not being there in person. But I guess you guys aren't there either, so it doesn't really matter. That being said, I want to say happy National Nurses Week to all the nurses out there who I know are tuned in and listening intently to us, all of my former colleagues. You know, not to be disparaging to physicians, but as we know, if we don't have bedside nursing, the whole system would grind to a halt very, very, very quickly, which really leads me to one of my questions. Perhaps I'll start with Dr. Smart. You know, I mean, we have seen a little tiny bit of movement in terms of retention about the loan forgiveness commitment from the government. We've seen that. You know, obviously, I think the roadmap is very comprehensive. If we could pick one thing out of this, what would the number one priority be?
Thank you for the question. It's a difficult one because I think there's so many issues clearly. I think from my perspective, I think probably the biggest crisis in front of us where I think there's some options here about what we could do is really the crisis in primary care, because when that part of the system's not working, it directly leads into the overload we're seeing on secondary care systems like emergency departments and specialist access, et cetera. So I think that's sort of the beginning of the challenge. And I think the challenge in primary care impacts physicians, nurses, and other healthcare professionals as well. So I think if we can start to really understand what that is, and I think you've heard from the witnesses today and in our briefs that we've provided to you really what those problems are, the pebbles in the shoes, so to speak, that are preventing that system from operating well. I think that will be really the beginning of the systems transformation that we need to get things back on track. So I think really understanding we need to be committed to that team-based care. That's what everybody wants across health professions. We need to address the administrative burden, and that, you know, in primary care applies to physicians. I think we are hearing examples of how nurses are also pulled into these other duties duties in hospitals that aren't really appropriate. So it's really looking at getting the right people to do the right things and getting people on track, recognizing that this old way of doing things is not working. It's not going to attract or retain people in family medicine. And this problem is only going to grow if we don't get serious about transforming that system. So I think if I had to pick one thing, which, like I said, it's hard to do because I think it's all very important, I think that piece is very foundational in terms of how the rest of things roll forward. And I also think the other aspect to that is the national licensure, because that really impacts the sustainability of primary care in rural and remote settings. And being able to make sure that physicians in those communities can get relief is critical to retaining them.
Great. Thanks, Dr. Smart. Through you, Mr. Chair, if I could, I just have two specific questions, one for Mr. Guest and one for Dr. Bouchard. Mr. Guest, you talked specifically about nursing training. How many more nursing spots do we need in Canada to increase that training amount? Do we have any idea now? We've talked about that we need 60 or 70,000 nurses. How many training spots do we need to begin to catch up with the numbers we need?
Thank you very much for the question. It's an interesting question that I think is difficult to answer, largely because we don't have enough data to tell us where we need the people and what skill sets we need, which it really adds to the challenge to really know. We do know that there are more people interested in going into nursing programs and becoming nurses than there are seats to take them. But the exact number is, I would say, a shot in the dark at the moment without an adequate national data strategy.
Great. Thanks, Mr. Guest. I guess that kind of rolls into some of the data collection that we all know we desperately need. And finally, Mr. Chair, through you, if I might, to Dr. Bouchard, we've talked a lot about administrative burden and that we need to help that, and we need to have people doing the jobs they're trained to do. Are there specific examples you could give the committee about, say, in a family doctor's office, the administrative burden, how we might be able to reduce that?
Thank you for the question. The administrative burden and paperwork burden certainly varies across the country. There's many examples to give. One is how our EMRs, our electronic medical records, function across the country, and the varied number we have and different vendors. So integration between the EMRs would certainly help. There's a lot of manual faxing that goes back and forth, tracking down additional results. And to be quite honest, repeated lab tests and diagnostic tests just because you can't track down results. That would be one concrete example. The other one is integration between family physicians and all the specialists they refer to. So most of that is done via fax. There's back and forth with specific forms or different types of forms. That certainly, if we had an integrated EMR system, either a single source system or systems that talk to each other, that would greatly decrease that burden.
Great, thank you for that. Mr. Chair, I think I have a few seconds left. Dr. Smart, maybe quickly about the Pan-Canadian license. Are any concerns about that adding to the administrative burden in the sense of another layer of government?
I think that's an important question. Our vision for that is not that. It's really that it would be a seamless process with all the provinces and territories participating, that it would be, you might want to think of it a bit as one-stop shopping, so to speak, if those agreements were in place. I think the goal is not to increase the burden on physicians in terms of pursuing their license, but rather to streamline it, recognize that the requirements really are essentially the same now, but there's all these administrative steps that people have and cost to pursue licenses. So if we were able to streamline that, I think it could really make the actual administrative aspect and the cost less, bringing that burden down and giving us much more workforce deployability and flexibility.
Thank you, Dr. Smart and Dr. Ellis. Next, we're going to go to the Liberals. Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for appearing today. I also want to recognize that this week is National Nursing Week, also Indigenous Nurses Day. I want to thank all Canadian nurses for their tireless work. So my first questions to Mr. Guest. Mr. Guest, we all know we heard back in the committee, nurses are leaving their profession. What kind of resources, what kind of support we need to be given to them so they are not leaving this profession?
Thank you for the question. I think it's multifaceted. What we hear from nurses are one of the reasons they're choosing to consider leaving the profession is their workplace environments. They're talking about working short, having in excessive workloads where they're looking after twice as many patients as they normally should be. They're complaining about feeling like the quality of care has deteriorated along with those environments. They're talking about situations where they're being asked to work 24-hour shifts. We wouldn't allow a pilot to fly a plane doing a 24-hour shift, yet in some places we'll allow a nurse to work 24 hours. We're hearing a lot about burnout issues that are continuing to impact nurses, a significant deterioration in the self-reported mental health status of nurses that was already an issue prior to the pandemic, and it has drastically worsened. And so we believe that what needs to happen is we need to address some of those situations in workplaces that are creating stress, but also there needs to be mental health supports and other supports to help clinicians who have had very challenging experiences during the pandemic to get past those, very similar to what supports have been put in place for first responders, like PTSD supports and some of those mental health supports in order to help clinicians deal with some of the tragic things that they have experienced.
Thank you, Mr. Guest. Next questions to Dr. Smart. Dr. Smart, we need to increase the number of trained healthcare workers. The budget proposes 115 million with the 30 million ongoing to expand the foreign credential recognition program and clear the way for 11,000 internationally trained professionals. How do you think that working with the provinces and territories, that this will help lessen the burden?
I think it's really important that we try to bring the healthcare professionals who are already in Canada into our system. And we know there's many examples of physicians, nurses, and other healthcare providers who are already here in Canada who have really struggled to access the system for multiple reasons. And I think this funding could go to trying to streamline that process. It's very expensive to go through the process. I know I'm now speaking specifically around medicine because that's what I am more familiar with. But we know there's issues in terms of the cost of pursuing that training. There's issues with having enough access to the apprenticeship model we use because foreign trained physicians need to spend some time with Canadian provider for practice readiness assessment. That's often unpaid work, and access to Canadian physicians that can provide that support and allow help to integrate people into our system and orientate them to our system is limited. So that is a barrier. And then the cost and the regulatory aspect, again, of then having their documents assessed and through our regulatory bodies and then being licensed is very expensive. So those, I think, are all processes that could be simplified, streamlined, and supported, as well as financial supports for those healthcare providers and foreign trained physicians themselves as they're going through that process, which would then allow folks to be successfully onboarded into our system. But right now, because the regulatory aspects of it are so varied, it's very, very difficult, and many people are never able to actually complete the process, and they remain not in the practice of medicine. And I believe this is a challenge across health professions. So I think if those dollars could be invested into better understanding how we can streamline that process and support people, I think we have more chance of successfly integrating those healthcare professionals into our system successfully.
Thank you, Dr. Smart. My next question is to Dr. Bouchard. Dr. Bouchard, how does Canada compare to other countries when it comes to foreign credential and medical school acceptance? You said the matching number is very low.
Thank you for the question. I think the entry into residency into different countries is significantly different to be difficult to compare. I would say, certainly as you mentioned, that really the number that we're worried about is matching Canadian medical graduates into family medicine residencies in Canada. And that's the trend that is worrying over recent years. As far as training enough family physicians into the future, Dr. Smart already touched on, increasing the credential pipeline for international medical graduates, absolutely. But I would also point out that there's a significant number of Canadians studying abroad who finish their medical degree abroad and then are unable to match into a residency here. So it's both having more residency positions, but also making family medicine a more attractive specialty.
Thank you, Ms. Sidhu. And Dr. Bouchard, suite c'est le tour de Monsieur.
Mr. Garon from the Bloc Québécois. 6 minutes, please. Thank you, Mr. Chair. I'll take this opportunity to thank all of the workers in the healthcare sector in Quebec that have done extraordinary work over the pandemic. Of course, this applies to all members present amongst our witnesses. I'd like to start by saying that I love your brief. I love the fact that I have a timeline here, that I can really see your plan, that I can have this concept over time. It really helps. After reading the brief, I worked through it and I looked at the budgetary measures that would be required in order to apply or enforce this or bring about this plan. You're talking about the burden, administrative burden, several million, primary care, $3.5 billion, $4.5 billion for this workforce, etc. If you add the $2 billion in additional funding in the most recent budget for surgeries that were postponed, at this point, we're at 10.75, or actually $11 billion in additional funding that would be required over a 5-year period to address problems that were made worse by the pandemic, but that existed already prior to it, for instance, issues of retention. When you look at these figures, would it not be a better idea to simply respond to the provinces and when they ask for an improvement to the funding through the transfer, the Canadian health transfer, which would allow the provinces to have the flexibility to act? Dr. Smart?
Thank you for the question. I think it's definitely a challenge that we find ourselves in now is how do we try to leverage some of these ideas that are pan-Canadian issues and actually get some momentum on solving issues that impact everyone, as opposed to continuing completely siloed, which is our current 13, arguably 14 healthcare systems that we have. I think we absolutely appreciate that the provinces need to deliver on healthcare, and there's that important role, and that local knowledge or more local knowledge is important, but we also struggle with being able to take and learn from lessons of what's working and scaling it in other jurisdictions, and what we end up with is no real transformative change that's happening. We absolutely support the idea of increasing the Canada Health Transfer so that the provinces have more predictability in terms of the sustainability of funding that's available to them. But we also see that several of these problems we've outlined are pan-Canadian problems and may be more efficiently handled by having solutions that every province and territory can collaborate on and move forward together, rather than recreating solutions at each province and territory and not learning or scaling things that do work. We also, recognize that has been our pattern of funding now for many years, and we have not seen significant healthcare transformation. So I think our real concern is how do we move past the status quo? Integrated team-based care, we've been talking about this for 20 years, but we haven't seen any really high-level commitment towards making that the system of care. So how do we get past the status quo? How do we get the province and territories and federal governments cooperating towards the action that's needed to transform the system? And how do we move forward out of this crisis mode? And I think the worry is more of the same is not going to get us there.
Merci beaucoup.
Thank you very much. I have a question for Mr. Gast. A lot has been said about immigration, to really foster more immigration. In this sector, I've spoken to my colleagues across the way about this, and what's interesting is that Quebec chooses its own economic immigrants. I know it's a priority for the Quebec government. I would like to know this. When we're looking at specifically immigrants in this sector, this approach that you've taken in addressing the federal government in this way, have you done the same thing with the government of Quebec? Have you express to what extent this is a priority?
Thank you for the question. We actually have had communication with all of the provincial and territorial departments of health. The communication that we've sent to the federal government, we've included to all 13 provinces and territories, recommending the same approaches to them all. And I would say that when there's a need for us to reach out, we do. We tend to focus at the national level in a federal way, and support our colleagues in the Quebec Nurses Association to advocate locally with the government in the province of Quebec. We tend to not interfere in those processes, but very much we have provided information to all of the provinces and territories related to our recommendations long before actually the roadmap was in place.
Et très rapidement,
Quickly, Mr. Guest, you're not the first person to tell us that we really need to improve the quality of information and data that we access, or we have access to develop our healthcare policies. What do you have in mind in terms of data collection method? What would you have that would be more collaborative for the provinces, or is it something hugely centralized within the federal government? What's the big idea behind this?
Yeah, thank you for the additional question. We are not as specific in recommending the final outcome of how the data collection occurs. I think what's more important is that it's expedient, and that there are national standards in the data that's collected so that we actually have information that tells us something. Currently, we see siloed information. It doesn't have the same meaning, and it's very difficult for us to make informed decisions across the country with respect to what our needs are. And so we suggest a number of options. We supported recommendations that have already been put out, and it could be a new organization that the federal government creates. It could support a not-for-profit organization similar to the Canadian Partnership for Cancer. Largely, we don't have a specific recommendation as to what the structure is, more the outcome, and that the outcome happens quickly.
Merci, Mr. Garand. Thank you, Mr. Guest. Next, Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, witnesses. Happy National Nursing Week and happy Indigenous Nurses Day. And I want to congratulate all of you and thank you for bringing solutions to the table. I think we've had a really good description over this study about the problems, but I think what we really need to focus on are how we can address the problem that I think everybody is very well apprised of now. I'm going to start with you, Dr. Bouchard. In your view, how would national licensure help with improving access to primary care? I know that would help docs move, but how does that actually help with the the issue before the committee?
Thank you for the question. I think it helps in a number of ways, a few of which Dr. Smart has touched on already. One of them is certainly around locum availability. So we hear that from our members constantly, that currently disparities in staffing across the country often leave them unable to take a break from their practice, get a locum in to cover their practice while they're away. And a national licensure would certainly provide that mobility to allow that to happen. Certainly short-term locums right now, specifically. So it can take a long time, in addition to the money, to get registration in a particular province. The other one that we hear often is around border towns. So we have a number of communities across the country, of course, some closer than others to borders, and some particularly far away from their tertiary referral centers, where getting locums could happen, maybe an hour down the road versus trying to get somebody from elsewhere in the province, and that would help with that. My hometown is Lloydminster, Saskatchewan, Alberta. It's cut right in half in the border, and right now you need 2 licenses to practice on a daily basis there, so not just the locums. But those are two I would mention for sure.
Thanks, Dr. Smart. I'm going to pivot to you, Dr. Smart, to elaborate on that. And I know we've spoken before about virtual care and how that might actually play into national licensure. So I'm going to ask you to comment on that. But I'm going to add to that. You mentioned that a mental health strategy is a key component to dealing with this. What should that consist of?
I'll maybe start with the licensure issue first. So in terms of access to care, we know that one of the things that's really challenging right now too is streamlined access also to specialist care, and that impacts primary care providers as well, because a major source of burnout for family doctors is being unable to get their patients the care they need in a timely manner. So I think we can support family physicians by streamlining the process they need to go through to access those consultations and collaborative care for their patients. And virtual care is a tool to allow for that. It's also a tool that creates more flexibility in terms of who can be providing the care to who. So we can be better leveraging different availabilities and different wait times from across the country, which we don't do now. I think good access to virtual care is also important for family physicians in terms of ongoing continuity of care for their patients. It gives them more flexibility in terms of how they meet the needs of their patients and in what context, so that they can better utilize their time and their patients' time. Meaning, if something doesn't need to be done in person, a lot of people prefer it to be done virtually because there's also an impact on the patient who has to, take time off work, park, wait in your waiting room, versus a quick virtual appointment. Sometimes for those ongoing things between the longer appointments in a patient-doctor relationship can be quite efficient. So I think there's ways of utilizing it to improve the doctor-patient experience, to allow family doctors to deliver the right care through the right mode at the right time for their patients, which strengthens that doctor-patient relationship, and then access to specialists. Utilizing virtual care, I think, can make things easier for family doctors and also get them the support they need, given the increasing complexity and aging population, to continue to do their work. And I think that's particularly relevant for those of us who practice in rural and remote parts of the country, where the burden of travel for families can be substantial to access that care. And often the same things can be achieved collaboratively in utilizing virtual care. So I think there's lots of pros there. I think the other aspect of that is increasing access virtually can also support the continuing professional development for physicians, which is another challenge when you live in rural and remote places. So there's many aspects to that are positive. In terms of the mental health piece, we know that the mental health of physicians has dramatically declined during the pandemic. We're hearing, over 50% of physicians have severe burnout. It's almost doubled from the beginning of the pandemic. A significant portion of physicians are reporting clinical mental health concerns. So I think we need to have more access for doctors so that they can address those issues. We need to destigmatize that. We do have some ongoing challenges where those types of issues, health issues, need to be reported to regulatory colleges, and that can be a barrier for doctors seeking that care. So I think we need to destigmatize mental health and recognize physicians are people and they have these issues just like anyone in the population, and we need to normalize that and support them. And then we need to make sure that those supports are readily available where they are and in an easy way, so that it's not a barrier to reach out. So I think the government could be supporting those programs, making sure that they're available for doctors, so that we can access that care and be in our top form, so that we can continue to care for the patients when they need us.
Thanks, Dr. Bouchard. I'm sorry, to the nurses, I'll have to probably come back to you, but I'll just quick question. Is there a viable IT solution to the data problem you described?
Not currently.
If possible.
Sorry, I meant that to the nurses too, if I could, to Mr. Guest.
No, there isn't. Each province and territory is collecting information separately, and what we actually find is we have to sometimes go facility by facility. Individual provinces, some of them don't even know what their workforce data needs are. And so I think this is more difficult than just a simple IT solution.
Mr. Guest and Mr. Davies. Next, Mr. Lake, please, for 5 minutes.
Yeah, I'm gonna continue on the mental health path here. It was Mental Health Week last week, and had the chance to meet with several stakeholders, and I've had the chance to meet most of you individually as well. This is a great panel. Thinking about mental health, as I've been kind of thinking about it as it relates to what we're talking about, I kind of in my head organize in sort of three different areas. So, there was what Dr. Smart talked about a few seconds ago, which is the actual mental health directly of medical experts, our medical professionals. But first, of course, you're dealing with the mental health of the broad population as well, and the impact on health broadly. Then you're dealing with the mental health of individuals that are coming and interacting with you. And I can imagine that right now that's particularly difficult in many, many circumstances. And then, of course, you're dealing with the mental health of professionals. Is that a kind of a good encapsulation? Is there a part of the equation that maybe I'm missing there? Anyone? No. Okay, so
I can comment on that if you like. I do think that is a good framework, and I agree that I think those things all interact with each other, absolutely. And I think, again, when we look at, I think burnout really directly relates to mental health for many providers. The more you're burnt out in your work, the less joy you find in your work, the more the people around you are burnt out. It means those normal, interactions we have with each other as colleagues can become more negative, and all those things just drive your mental health not being optimal. And then the other side of that, as you alluded to, is when our patients are really struggling and we don't have the resources to help them. That is also very challenging. And I think as the needs of Canadians have become more complex, both in terms of aging population with more complex medical needs, but also the growing mental health crisis across the country, which is incredibly prevalent. 1 in 4 Canadians at least dealing with concerns with their mental health. And then we're downloading that onto this broken system that doesn't support people in the way they need. That burden, again, is often borne by individual physicians and other healthcare professionals who are very distressed at the fact they can't get patients the care that they need. So I think those three things all do interact. I think it's circular. I think they build on each other. And if we're not addressing it holistically, I don't think we're going to solve for that problem.
And Dr. Smart, you mentioned the $4.5 billion Canada Mental Health Transfer Promise. And as I was having conversations with stakeholders last week, more and more concern raised about the fact that money hasn't been delivered. So the promise specifically was $4.5 billion over 5 years, but $250 million actually in the last fiscal year was what was promised, and over $600 million this fiscal year. And of course, in the budget, we just didn't see that. So, taking away the whole $4.5 billion and just thinking about almost $1 billion that was promised 8 months ago in an election campaign to have been, allocated at this point in time for a Canada Mental Health transfer. How important would that almost like $900+ million be at this point in time to addressing some of the significant issues that we're facing?
Well, I think it's very important. I think we're starting to see a growing alignment on what the priorities are and what the challenges are, but it is very difficult to move from this conversation to the action without the resources. So I think that next phase of funding and providing the fiscal supports to drive these changes is essential.
Does Dr. Bouchard or Mr. Guest, did you want to weigh in on that? Because this is, again, a clear promise that was made, a commitment to be spending this money right now, almost $1 billion just last year and this year alone. How important, how far would that money go to addressing some of the concerns on the mental health side that we're facing?
Thank you. Yes, I'll expand on that. So Dr. Smart, of course, mentioned without resources, we cannot move. Either provincially or federally or collaboratively. I just want to emphasize for the family physicians, we need the resourcing both for ourselves, but we need it for our patients as well. And particularly around coming back to team-based care, we can't address patients' medical health. We can't address our own mental health. In the 5 to 10 minute visits that family practice has traditionally been. We need that team-based transformation to address mental health as well. So it's all interconnected. It's not just the mental health of providers, certainly.
Thank you, Mr. Lake and Mr. Guest. Next.
I, like my colleagues, would say it's vitally important. I think the one thing that I have to add, though, is that the additional money is not going to be the only solution when we're looking at a mental health system that also has vacancy. When we looked at the last 2 years with registered nurses and registered psychiatric nurses alone, there's been over 100% increase in the number of vacancies. And so we need to be careful that we don't assume that the additional dollars are going to be the only thing that's going to be needed for a solution to this issue, because we would be sadly mistaken.
Thank you. Next, we're going to go to Dr. Pawlowski, please, for 5 minutes.
Thank you, and I want to thank all our guests for their recommendations, and there's certainly a lot here. I would suggest that, in my mind, the one that is key in getting more doctors into underserviced areas and to getting more nurses across Canada is recommendation number 6, training and licensing for international medical graduates in internationally educated nurses, and it's an action plan to get internationally trained doctors, nurses, and nurse practitioners to work. And certainly, I think that in underserviced areas, people don't really mind so much where you come from as long as you can do the job. And I say that having worked in 6 different countries and in all kinds of places in Canada that are underserviced. Now, part of your policy recommendation number 6 recommends increased opportunities for experienced foreign-trained IMGs to complete practice-ready assessments. So I wanted to ask both Dr. Smart and Dr. Bouchard about that recommendation. And we talked to a witness earlier on in this study who suggested they thought there was only a couple of hundred such positions available across Canada per year. Would having more opportunities for foreign graduates to take part in these practice-ready assessments allow us to get more foreign graduate doctors licensed?
Thank you for the question. There's a number of aspects to this. Certainly, there's, again, as Dr. Smart has mentioned, we've all heard of physicians who have trained abroad who now live in Canada and are Canadian and are unable to enter practice. So increasing resources to the practice assessment bodies, the credentialing bodies that do those assessments in each province is certainly one path forward, and we would support that. I think it's important to recognize that Canada must demonstrate a positive working environment for physicians in order to attract them into family medicine. And we've outlined a number of concerns around family medicine broadly that we need to address as well. Another aspect of this is the concept of ethical recruitment. Certainly Canadians who have immigrated from abroad who are now in Canada, I think that's a clear line, including Canadians who have left to study abroad and have come back. There's a pool of resources there.
Sorry, can I just interrupt you there? And that do you think would the federal government, or would there have to be more money available for the colleges of physicians and surgeons across Canada in order, are they the ones that create the practice-ready assessments? And if they had more money, would this open up more positions? Is that part of the roadblock?
I won't speak for the regulatory colleges themselves, but certainly we know that it's a resource-intensive process to do these practice-ready assessments. So I would assume more resources are required. Sorry, I can't be more specific.
I think the bottleneck, if a bottleneck there is in the level of capacity to do the assessment of a physician who has come from another country, in terms of assessing and working with that physician around making sure that the physician is competent to perform in the Canadian environment, and that capacity is one of the limiting factors.
Now, our government has promised money in order to make it easier for foreign graduates to get licensed in Canada. Is it as simple as having more money available to the colleges to do these assessments? Is that the answer, or do physicians not want to do the assessments, or do they not have a lot of trainers, or exactly where is the roadblock? Because the government does want to address this, I think. And so is it just a matter of more money, or are there other things that we'd have to do to get more of these assessments done? Dr. Smart hasn't said anything. You look like you want to say something.
I can comment. I think, as my other colleagues have said, I think it's challenging in that it's not just one issue. I think that the funding is one aspect of it for sure. But again, there's also the challenge around the capacity of having the physician assessors able to take on more of these folks to help them go through the process. And again, I think what you're hearing is we're sort of layering that on top of family physicians who are already quite overburdened in their practice. And I think that's where it can get very challenging in the system, because we're trying to leverage the same people in multiple directions at the same time. And it's hard to keep adding to that. So I think we need to really be thinking about, what does that look like? What is that process? How do we support and make that attractive for the physicians who are doing the assessments, so that it's something they can fit into their workflow? And then how do we make sure that it is appropriately funded? And also the folks going through that assessment are then funded so that it's something reasonable for them to be able to accomplish. Sometimes they're needing to do that with no financial support, and that's a big barrier. So I think absolutely the finances is one piece. But I think as you're just hearing broadly as a theme today for all these issues we're talking about, the dollars are not the only issue for any of these problems. There's really significant structural issues. There's significant capacity issues. And if we don't think about those two things in parallel, I don't think we're going to solve the issue. More money for something that's not working isn't going to suddenly make it work. So we need to, I think, understand what's working, what's not. How do we scale the things that are working? What substantial systems changes need to be made? And then how do we support those new ways of moving forward so that it becomes sustainable?
Thank you, Dr. Smart. Dr. Pawlowski, suite Monsieur Garand pour 2 minutes et demie.
Mr. Gallen, you have 2 minutes. Thank you, Mr. Guest. I'd like to focus on your third recommendation, which I find quite interesting, which is to make $3.2 billion available to the provinces and territories to really highlight the profession. Over what time frame are you asking for this amount of money? It's not written in the plan.
To be honest, I don't have the answer to that, but I will make sure that I get it back to you.
Pas de problème.
Okay, no problem. On another note, you don't have any details, of course, on the modalities or the terms of this transfer. $3.2 billion that you're suggesting. I understand you really were focusing on the needs of Quebec and the province, the terms, modalities, the conditions. If this amount were to be dispersed to the provinces and Quebec, could you tell us what these various governments could do in order to really highlight the beauty of the work in these two fields?
If that question was directed to me, actually, I think Dr. Smart would be a better person to answer it, because it's very much focused on primary care. And so I think I would defer that to her.
Dr. Smart.
Dr. Smart?
Thank you for the question. I think really what we're looking for there is, we heard in the election campaign this figure of $3.2 billion to improve access to primary care. And I think where we see that making an impact is really trying to address what is making primary care not work today. And I think you've heard from us today what many of those issues are, and we'd like to see those dollars directed at moving towards integrated team-based care and really changing that model of care so that patients have a medical home with a variety of providers who can meet their needs, which in turn will create a better working environment for family doctors, make family medicine more attractive and appealing, therefore retaining the people that are already family doctors in longitudinal practice, and at the same time making it a more appealing area of specialization for our new medical graduates, as well as allowing other healthcare professionals to work at top of scope in a team, which also will increase their job satisfaction, and it sort of builds on itself in terms of the success it would bring, I think, in that regard, and improving access to care for Canadians. So that's really where we would like to see that money go. Again, I think we know that just more doctors isn't the solution into itself, because if those physicians are not satisfied in their work environment, or that work environment's broken, they're going to leave and do other things. And that's what we're seeing now. Many family physicians are practicing medicine, but they're not practicing in a primary care model in a community with a patient roster. So those dollars could go to changing that practice environment so that family doctors actually want to be family doctors, and the people that want to work in these teams providing primary care to Canadians are able to do so longitudinally.
Thank you, Dr. Smart. Next, Mr. Davies, please, for 2.5 minutes.
Thank you. Mr. Guest, you spoke of the crisis as being one more of retention than recruitment, and I take that at face value. But you also mentioned that workloads were a problem. And now I'm putting together a vision in my mind that I've heard that as hospitals have cut cleaning and support staff and admin staff, a lot of those duties have been thrust upon nurses. So I can see that adding to their workload if they're spending a couple hours of their shift doing cleaning and administer. So I see how adding, bulking up the administrative and cleaning staff would help. But does it also not speak to the fact that we need more nurses on shift as well? And if so, can you help me quantify that?
Thank you for that question. I think it's all of that. You know, to add some context, you know, we've added a number of things to the work environment that nurses work in. Some of it is related to them doing tasks that are non-nursing related tasks, and we've seen examples of that as some organizations, for example, have implemented new electronic health records that are more integrated. Some of them have reduced clerical supports as physicians do more of their physician orders themselves, yet there have been tasks that were left behind that those clerical people were doing that get downloaded on nurses. That's as an example. I hear of nurses needing to clean beds in some facilities at night for admissions because there are no cleaning staff in facilities. You know, there's a couple of examples, but some of the others that we're hearing is hospitals across the country, many are over capacity, and that adds to the workloads that nurses are experiencing. But what makes it more challenging is that they sometimes are coming into work that day when they're short already. And that's part of the challenge when you have a system that's got a significant increase in vacancies that you're not able to fill, yet you haven't adjusted the work with the workforce. We've continued to operate many of our facilities full blast, yet we have a workforce that's depleted and isn't at 100% capacity, yet we're expecting them to continue to do the same work volume. There needs to be some balance there, and part of that challenge is it creates additional stress, and more of those workers choose to want to leave because they don't want to come into work, not knowing if they're going to have 5 patients that they should have or 10, or if they're going to get to go home at the end of the day, or they're going to have to work 16 hours because there's no one coming in to relieve them. Those are the challenges. It's not just about needing to have more of a workforce. It's needing to look at all of the issues and balance them all out together.
Thank you, Mr. Guest. Next, we're going to go to Ms. Goodridge, please, for 5 minutes.
Thank you, Chair, and I, too, like many of my colleagues, would like to start out by thanking all the spectacular nurses that make our healthcare system run, and a special shout out to a friend of mine, Katie. You do amazing work, and we are very proud of all the work that you do for our community. But so specifically, I was reading an article from last week that was in CTV Vancouver, and it was talking a little bit about how there is an unknown number of patients in BC that can't find a family physician, and yet in Alberta, because of some boards that we have, and the College of Physicians and Surgeons have a directory that allows them to show how many doctors are accepting new patients in Alberta. They could give a precise number. And so often on this committee up to this point, we've heard a lot about statistics and how the statistics are kind of haphazard all across the country. And I'm just wondering, perhaps start with Dr. Smart, are there any jurisdictions that are doing the statistics piece better or worse?
Thank you for the question. I don't have a direct answer for that because I'm not familiar with exactly how each jurisdiction is collecting statistics. I think we sort of see different jurisdictions reporting different numbers and different things at different times, and some things on the surface at least seem to be better than others. But I would be hard for me to say, exactly where you would want to be looking to sort of for best practice. But I think what needs to happen for sure is standardization across the country in terms of data reporting, and also to make sure that we're talking about the same things. So, just as an example, when we're talking about surgical backlogs, some of the ways the provinces are generating those data is varied. So it's not always reflective of the on-the-ground experience of patients or physicians. So I think part of having good data collection is really standardizing what we're talking about when we're talking about different data points and making sure that it's reproducible and that we're talking about the same things, apples to apples comparisons.
Fantastic. Perhaps Dr. Bouchard has an answer for that same question?
Yeah, all I would say is every province is doing it differently, and that's why we need some unification around this. Certainly some provinces are relying on fee-for-service billing data, and I would emphasize on that point as well that a family physician is not a family physician. There are provinces that have made it clear that they think they have enough family physicians, and yet there are a significant proportion of patients that are unattached. And obviously those both can't be true at the same time. We really need to capture how family physicians, how all healthcare workers are practicing, whether it's comprehensively, focused practice in emergency, addictions, et cetera, in order to know what we need and where we need it.
All right. And then I guess to follow along that same lines, if you could design a system, what would be the system that you would design to help make sure that we had a handle on our health resourcing?
Thanks for the question. I would say I don't think we would be so prescriptive other than to say that it needs to be national in scope. It needs to be standardized, and it needs to be shared data as well in order to inform these health workforce planning into the future. As Mr. Guest has said before, there's many ways to accomplish this. The issue right now is that we don't have the data, and where we'd have the data, it is collected in very different ways and different forms in different places in the country.
Fantastic. And so then I guess to go on to a different space, Mr. Guest, just wondering if you had any thoughts when it came to some of the data that you're seeing, and if there are any jurisdictions you might be able to point to that are doing it better.
Thank you for the question. Yeah, I haven't directly had the opportunity to observe how each province and territory is actually collecting data. I can tell you based on my personal experience that Nova Scotia has done some really good work in this area, particularly on the non-physician side of the health workforce. They work very directly with their advanced education colleagues, and government is heavily involved in the process, and they work collaboratively with the regulators. And so there is an example of some that are, I think, doing a fairly good job where we could replicate some of those processes. I think Dr. Bouchard's comment was the key, is that we've got 12 or 13 approaches to how we do things. And it's not so much about everyone having to do the same things or someone taking over and doing this for the provinces and territories, but the provinces and territories and the federal government coming together, agreeing on a standardized nomenclature for how the data is going to be collected, and a centralized place collecting it for them so that everyone can access it for better decision making. I think that's what we believe is the important approach.
Well, I think that's elapsed my time, so.
Yep. Thank you, Ms. Goodrich. Mr. Guest, next, Dr. Hanley, please, for 5 minutes.
Thank you, Mr. Chair. And thanks, I echo thanks for all the witnesses for reappearing and for bringing the roadmap, which speaks to solutions. And also, like my colleagues, I'd like to recognize National Nurses Weekend and Indigenous Nursing Day. Dr. Smart, the situation is so critical, and that we find solutions, establish recommendations. In addition to the roadmap that the three organizations have brought to us, you released a statement today, just today, I believe it was, on the need for the federal government to lead in collaboration with provinces and territories, a drive to increase Canada's supply and availability of family doctors. And I think this is critical. And what I really liked about that statement is you talk about reimagining family medicine, which goes back to that concept of reforming primary care. And maybe a few words on what does the modern, happy, useful, efficient 21st century family physician look like? Let's project a few months or a couple of years into the future.
Well, I can make some comments, and then of course would love to hear from the two family medicine experts we have here today. I've really tried to take the approach in this role, and I think the CMA's really tried to take the approach of listening to the people that are experts in family medicine regarding what are the pebbles in their shoes, what are the things that are preventing them from doing this work. Every family doctor I've encountered and met through my career has chosen that area of medicine because they really believe in wanting to provide longitudinal continuity of care to families, from birth to death. And the fact that the system is taking that joy in providing that type of very meaningful care away from them, I think speaks to the fact that it's fundamentally broken. I think, what family doctors want is they want to be able to provide that care without having to worry about all the business aspects of medicine, of rising inflation, rising costs of providing the primary care infrastructure, rising administrative burden, inability to spend the time that their patients need from them to address complex issues, and not having the team around them to provide comprehensive care. So, I think if we project that to the future, I think what they want is they want to be on a team where their patients have a medical home. That medical home means that the provider that patient needs is available to them for the problem that they come with, that they're seen as a whole person, that the care is comprehensive around that, and that their job is thinking about patients and what they need, not thinking about how do I run this small business and how do I work through this fee schedule of 18,000 different fee codes and manage all my billings and all these administrative pieces that really detract from the heart of what medicine is, which is a relationship with our patients. So I think if we can get back to that, really look at what it is Canadians need to have those healthcare issues addressed, I think we can have a healthier population, a healthier workforce, and a new sort of future for family medicine where it again becomes one of the most desirable areas of practice for new doctors.
Thank you. And Dr. Bouchard, let's flip that around a bit. And in this primary care team anchored by that happy family physician, tell me about that, the patient and the client in the middle, and how are they going to benefit?
Thank you for the question. Dr. Smart did an excellent job of detailing our vision and how we'd like to practice. I think the benefits to patients are innumerable. Family physicians are trained in complexity care in a complex health system, complex diagnostic and treatment options. And we want to be able to work at that top of scope and have other providers around us to not be focusing on the business. And if we're able to do that, patients absolutely benefit, certainly in longitudinal care. So I would like to have patients attached to my clinic that I see from birth to death. I understand themselves, I understand their context, I understand their family, their values, what they want out of their care, what their goals in life are. And I think the evidence is out there that we provide better, certainly more efficient care for the dollars invested into that. And that's where the primary care integration fund comes into. If we can transform that, that's why it's a time-limited fund. If we can get there into these team-based practices, it will be more efficient for the healthcare system and patients will benefit.
Thank you. And back to you, Dr. Smart. Clearly there are federal investments either committed or committed either in the budget or through the platform commitments, mental health care, primary care reform, backlog, addressing the backlog. But as you've all said, it's more than just money. So how do you see and you spend a lot of time talking with colleagues and associations around the country. So how do you see that the federal role in igniting change? We're in a federated system. The provinces have control over healthcare delivery. Yet we need a driver. We need to get there. And so maybe Dr. Smart, you can comment on how best the federal government can position itself in 30 seconds or less.
He's used 30 more seconds than he's allowed. So he's when he said 30 seconds or less, he might have been exaggerating. Go ahead, Dr. Smart, as concisely as possible.
I think leadership to define that integrated team-based care is the gold standard and the future, and that needs to be the model, and anything less than that is not going to cut it in 2022. So we need to define ourselves from that benchmark moving forward.
Well done. Thank you. Mr. Lake, please, for 5 minutes.
Well, thank you. And this is a great study. I want to say, first of all, my experience, and I've had some experience, unfortunately, with the healthcare system, with people close to me and myself, but it's always been great experience when we've had something urgent. I had encephalitis when I was 31. I'll tell you, it was taken very seriously, and I was very, very happy to have the support that I've had. I have a son with autism. I know, Dr. Smart, that's something close to the work that you do. When we've needed help with him, trying to figure out what's going on because he's non-speaking, we've always had fantastic support. But in those interactions, I've also notice things that just seem inefficient, right? And we all probably have at different times, the times when I haven't had as serious an injury, playing hockey, for example, and have to go into emergency because I don't know where else to go, and you wait for hours and, because there's more important cases, and that seems kind of inefficient in the general scheme of things. It doesn't feel like I need to be there, but it's the only place that works. Or, going to my own doctor, my family doctor, and who is fantastic, but seeing him do a lot of administrative stuff as he's working with me and taking notes and things like that seem very inefficient. It seems like a big part of the challenge is people doing things largely that someone with different training or less training than experts, the expert training people have, whether it's doctors, nurses, or others, people doing things that they don't need to do. Can you, when you think about those sort of expensive inefficiencies in the system, really expensive. I think, someone going to emergency that doesn't need to be there, or having a doctor taking notes, or, Mr. Guest talked about nurses doing cleaning. Those all seem very expensive to be very expensive inefficiencies. What are the ones that are the easiest probably for us to address as we think about action coming out of this set of meetings?
That question for me?
For anybody that wants to. It's just such a great group. So
I'll let someone else talk because I've talked lots.
Dr. Bouchard's unmuted.
Sure.
So
sure, I'll take a stab at that. I think probably the most essential component of that of building efficiencies into our system is moving to what the CFPC puts forward as the patient's medical home. That patient's medical home, that team-based care will vary across the country based on community demands. So we're not prescriptive so much about how each clinic is set up, which team members are involved, but exactly as you mentioned, focusing on what the community needs are, getting everybody in that team to work to top the scope so that we're using our resources efficiently is certainly where we want to go. And I think the 10 pillars of the patient's medical home and the resources of the primary care integration fund will get us there.
Can I think about, when I'm thinking about my own doctor and sort of family doctors, and you think, okay, they seem to be running small businesses of a sort individually, their own little small business. And my observation is that there's something, because if I come from a business background, if I was running a business of a similar size and nature, I would have support staff doing some of the things, and you would think that it would enable me to see more people, which the compensation comes from that, and that it would pay for itself almost in a sense if you get the right people doing the right supportive work. It's just an observation from the outside. What what gets in the way of that?
So I would say we're on the record as saying that alternative payment models, specifically not running your own business in a fee-for-service practice, is where to go. And I would say a couple of things get in the way of that. Family physicians are not trained to run a business. We're not trained to hire staff, manage staff, sign contracts, deal with remuneration. We don't want to be doing that. And unfortunately, that ends up, depending on the practice, being a significant portion of your day when you could be focused on clinical care, and is certainly contributing to burnout, especially in our urban areas right now with inflation and with increasing commercial overhead costs, medical supply costs, and everything else. So I think alternate payment models in a team-based practice are one way to make a substantial change to get away from some of the areas that are in the way of providing best care. The other one is certainly our IT solutions, or electronic medical record software. So if we were able to integrate those systems between referral centers, primary care clinics, hospitals even, it would save a huge amount of time for every team member, and would be a sustained win into the future.
Thank you.
Thank you, Mr. Lake and Dr. Bouchard. Next, Mr. Van Couverden, please, for 5 minutes.
Thanks very much, Mr. Chair. And through you, Mr. Chair, I have a question which might be a little bit technical. It doesn't need a specific answer or a really technical answer, but I'm really curious about if anybody has any sort of reflections on the potential proportions in terms of the contribution that could come to the Canadian healthcare workforce, whether that be through nursing or physicians, or any level or layer of the workforce that could come from the various. I was looking specifically at 5 and 6 from the joint submission. That's new training and education infrastructure, also new licensing. I'm also reflecting on the fact that if there isn't the capacity currently in Canada to educate new nurses and physicians at this time, perhaps creating simpler pathways for internationally trained Canadian nurses and doctors to come back and practice. But what are the proportions there? Does anybody have any sort of reflections? Like, is there one method that will sort of, contribute to the lion's share, or are we looking at an equal contribution from those various modalities?
I don't mind starting. Thank you for the question. The simple answer is there isn't. One of them that's the single solution that's going to be the biggest one that gets us out of the situation. It's multifaceted. It's going to need a multifaceted approach. We do know that there are a number of, from a nursing perspective, internationally educated nurses that are in the country that are struggling to get through the regulatory process to be able to be in the workforce. But it's not a massive percentage of the current nursing population that's going to be the solution to get us out of this. It helps. And I think the situation where we're at is everything that helps needs to be considered to deal with what is going to be a massive crisis. We are looking at growing vacancies, growing numbers of individuals in the current workforce that are looking at wanting to leave it, and a growing list of Canadians that are needing procedures and treatments that have been delayed for months. That is going to eventually have a negative impact on health outcomes, and we're going to be worse and worse in trouble. And depending on the same workforce to help get us out of it, there needs to be an all hands on deck approach, and we need to look at all of those situations. Both short-term, like helping internationally educated nurses become regulated, are registered to be able to practice. To be honest, I think they would offer something even if they were in the workforce doing all kinds of things, let alone waiting until they're registered. There's things they could do now to help them adjust and learn the system, but we need to do all of them.
Thank you, Mr. Guest. Does anybody have any other reflections on the potential contributions from various modalities, or should I move on to another question? I'll gladly move on. Oh, sorry, Dr. Smart.
I was just going to echo, I think, the same thing as Mr. Guest said. I think it is really, we want to be leveraging all possibilities, but I also agree that none of those things on its own are going to be the full solution. But they're all opportunities to bring more people into the system. But again, we need to make sure we have a system people want to be in. So we need to be doing those things simultaneously.
Thank you. And for clarity, I wasn't trying to reduce this to what one thing can we do to solve this massive problem, but just trying to get an idea of, if we're thinking that like 80% of the problem can get solved with these 2 or 3, and then the rest are sort of rounding errors. But I take the point that it's probably not. And we don't know, quite frankly, what the solutions will be until we start employing and engaging them. I read a relevant reflection this weekend about something totally different, about that we have all the solutions, we just have to deploy the solutions. It's not a matter of coming up with new ideas for fighting climate change or creating solutions for human health care resources or the lack thereof. It's a matter of deploying them. I have a question regarding the training. Obviously, this would be months and years down the road, so it wouldn't address the problem in the next 6 months. But would more scholarships for people entering this education be a little bit of a cart before the horse type thing because there are not enough positions? It also occurs to me that in most lines of work now, there is a capacity to have more people than desks, so that could possibly be true as well in nursing, because we have fewer desks here that could hold everybody in the meeting, but we're managing, so perhaps nursing schools and colleges could be training higher than a general capacity. But would new scholarships and bursaries for future students encourage more people to get involved?
I'll maybe make a comment from the medical side. I think right now what we have is not enough seats in our medical schools for the number of people that want to train to be physicians. So they're oversubscribed, and that's why you see many Canadians choosing to go overseas, primarily to Ireland and Australia. Those seem to be the 2 most popular places for Canadians to train in medicine, and that's largely because folks haven't been able to access medical schools here. So I think more capacity in our system is important. I think where scholarships are really important is when you look at the challenge of improving the diversity in our workforce and allowing the workforce to be more representative of all Canadians. Medical schools, incredibly expensive. Some of the things that are prioritized in people that apply in terms of extracurriculars, et cetera, really speak to privilege. They're not things that many Canadians would have been able to do. So I think, from my perspective, a really important part of serving Canadians well as a profession is making sure our workforce is diverse. And I think eliminating financial barriers to allow more different types of people from different backgrounds to become physicians is going to be critical for the future.
Thank you, Dr. Smart. Suite, Monsieur Garon pour 2 minutes et demie.
Mr. Garon, 2.5 minutes. Thank you, Dr. Smart. I was touched by the comments you made about access to care. Personally, I feel very much concerned about the access to care in areas like the Abitibi and the areas that I know where there's been a lack of resources, workforce, and hospital access. Over the last while, certainly there's been improvements with telemedicine, remote meetings or appointments, and that has changed practice actually in medicine, and it's allowed the system to be more fluid, and people have been able to access some of their appointments this way. Of course, not all appointments can be done online. From your perspective, what new resource investments are required from faculties of medicine in order to make sure that these medical schools can help us in our process in order to make these kinds of remote options available over the long term? What should be done?
I think there's a few things. One of the biggest challenges in remote areas, both for patient care and potentially for this idea of decentralizing some aspects of medical education to improve access for rural and remote Canadians, is the internet itself. I'm speaking to you from the Yukon today. The internet service here is very expensive and not of high quality, and I would say it's out of the probably what most people can afford. I personally pay over $200 a month for my internet, which is, I think, a sort of a shocking number. So we need to make sure that all Canadians have equitable access to communications technology. And I think if we, This virtual care revolution that happened so quickly because of the pandemic has been revolutionary in many ways. We're still, I think, figuring out exactly how to leverage that in the best way. But I think we're going to see some of those changes come for education as well, and getting away from thinking that everything has to happen in the big city necessarily at the university. There's some excellent examples already of distributed medical education across the country. I think we can continue to build on those models, and we need to look at what's working and how those are servicing Canadians wanting to be doctors, but we're going to have to make sure that that infrastructure is there for people so that they can get online effectively and be participating in these virtual experiences. And I think, again, that there's an equity concern there. If it's not available to everybody, that you again start creating two different tiers of access, both educationally and in terms of patient care. So I think that's an important area to focus on.
Thank you, Dr. Smart. Next, Mr. Davies, please, for 2.5 minutes.
Doctors Bouchard and Lemire, the primary care integration fund seems to be a core piece of your suggestions. I'm wondering, what advice would you give us in terms of considering, in terms of the implementation elements that we should bear in mind as we create and administer this fund?
So I think that we see the primary care integration fund as a fund that would be put in place for a temporary period of time to enable scaling up of some models of care that already show promise. So examples of this would be Groupe de médecine de famille au Québec, Ontario Health Teams in Ontario, primary care networks in Alberta. These are some examples that are models of care that support good integration, team-based care, and have been shown to show promise in terms of reduced visits to the emergency department, better adherence to preventative measures, and better satisfaction by patients and providers alike. So this fund would enable scaling up and provide support to family practices to get to that model of care. So because we know that investments are required up front, so that then you can reap the benefits at the back end in terms of some of the outcomes that I've described, as well as savings from a healthcare delivery perspective.
Thank you. I'm sorry, did you have more to say?
Well, you know, you and I have discussed this already, but probably making a fund available with a specific purpose, a targeted fund, doing some of the things I've just finished talking about, to which the provinces could apply, and hopefully they'll all be interested in accessing the fund to actually bring that scaling up of innovation.
Mr. Guest, I'm going to revisit a question. I think I didn't put it quite properly, but the question I asked you about, is there a viable IT solution? I know the problem is hospitals and provinces aren't talking to each other, and that's a major cause of grief, it seems. What I'm asking is there an IT solution out there for that? That's what I'm asking.
Yeah, to our knowledge, no. You know, we certainly have seen across the globe, there are countries that are doing a fairly good job at this, where there's some examples that I think we can learn from. The United States has a program where they're doing this. And so I don't think we have to start from scratch and recreate the wheel. There is information and knowledge that we can leverage. I think the big thing here is not so much the IT solution itself, it's the infrastructure in order to pull it off. A really good example of how this is already happening in the health system in Canada is CIHI. There's a federal agency that has the task of pulling together health information data that's collected by all of the provinces into a central repository. It's analyzed and it's provided back for the health systems to be able to use for planning. That's kind of what we're talking about, is standard an organization to help standardizing the data collection, that the provinces and territories would then flow up so it can be analyzed and be provided back for decision makers within the provinces and territories for better planning for health human resources strategies, whether that be educational seats that needed to be grown, whether it's investment that needs to happen in supporting clinicians to be able to practice in a subspecialty that may be needing to be grown. Those are a couple of examples.
Thank you, Mr. Guest. Next, Dr. Ellis, please, for 5 minutes.
Well, thank you, Mr. Chair, and I want to say how wonderfully efficient we are today. We've gotten through many rounds of questions, which is unusual for us, and no interruptions, which is also great from the bells. I'll respectfully disagree with one of my colleagues, Mr. Vancouverton, who talked about that we do have the solutions. I mean, part of the difficulty here is the understanding of the breadth of this problem and the significant change that's required. I mean, we need people, we need to create physicians, we need to create nurses. That takes time. We also understand that there's a tremendous shift away from choosing family medicine as a profession, as we heard about the unmatched seats during the CARMS process. And that is a tremendous change that we've seen over the last generation or so. So that creates to me a significant problem. I think there's two other comments that I would make, and I will farm out some questions, but one is team-based care is exceedingly inefficient. I've practiced in a team-based care at a chronic pain clinic for the last 15 years or so, and the speed with which we're able to see patients is much slower. We have to discuss them, we have to chart, et cetera, et cetera. So that's a difficulty. And I think the other comment I'd like to make is I'm not entirely sure that the government understands how dire this situation is, and I'm not entirely certain that every Canadian understands how dire the situation is. So because team-based care is a significant part of the roadmap here, I guess I would like to perhaps ask Dr. Bouchard to comment on the inefficiency of team-based care. And there certainly are many cases in family medicine, and I'm biased, I know, because I'm a late generational family doctor. I understand that. But there are many cases where you don't necessarily need to see a team. And how do you sort that out?
Thank you for the question. I think rather than the term efficiency, what you're perhaps alluding to is, the time per visit or the time per patient. Certainly, that would increase in a team-based practice and should. Patients are more complex. It takes longer to sort out problems. We were just talking about the mental health burden, both for providers but patients, and that certainly takes more time. Under a team-based care model that's implemented well, that doesn't necessarily equate to increased resources, increased dollars. Different team members working at their top of scope, and many team members that are not as highly trained and to be frank, as paid to the same level as family physicians would be incorporated as part of that. But it's also the healthcare savings we see. So Dr. Lemire touched on, even if certainly a team-based primary care clinic or network cost more directly, there would be significant indirect savings from reduced emergency department visits, which are much more expensive, and reduced hospital admissions, certainly. Certainly per visit, per patient coming into clinic, that may change, that may take more time. But having worked under both models myself, I think patients value it, and I certainly value it as a family physician to be able to take that extra time to sort out all the issues we hear, across the country. One issue per patient, one issue per visit, and patients don't like that. Family physicians don't like that, and I think we can do better.
I'd simply add perhaps that it takes time and energy to work effectively as a team. And I have experienced the same as what you've described, where you see a patient that's being seen by several different people before they get to you, and that's not efficient. So energy needs to be spent on supporting people to work well as a team. That needs to be a part of it.
Thank you very much. And through you, Mr. Chair, to Dr. Lemire, giving kudos to the amount of work that you've done on this particular project over the years, how likely do you think that we're actually at this time, because you've seen this through many iterations, many reports, what's your confidence level that we're actually going to be able to get there this time? I know that's a politically loaded question. I appreciate that, Doctor. I do.
Yes.
But
the only thing I will say is that I think that we all realize, all of us today, that we are at the point of inflection with regard to how primary care and community-based care is functioning. And I think we all realize this now more than ever. And so I would suggest that we are at an important crossroads, and that I sense that there is a will, a genuine will to invest in a future that will not be a repeat of the past. And so I am more confident than I have been in the past, but I certainly will not put a percentage to it.
Thank you.
Well said.
Dr. Lemire.
What a great way to end, Mr. Chair.
Dr. Pawlowski, please, for 5 minutes.
Having practiced medicine for a lot of years and having worked with a lot of nurses over those years, and certainly recommending the key pivotal role of nurses in the healthcare system, let me ask Mr. Guest some things about the problems facing the nursing profession. Any of us who work in medicine realize how overworked a lot of nurses are, particularly in hospitals, how they're always being asked to work overtime, extra shifts, having too much work to do because they're understaffed. In your recommendation number 6, you suggest support, this is presumably the government, support and expand opportunities for registration and deployment of internationally educated nurses in order to provide immediate supply into the workforce as done in provinces such as Manitoba and Ontario. We haven't been doing this long enough that we've talked to people from each of the provinces. Mr. Guest, could you tell us what Ontario and Manitoba did?
Ontario is more recent. I'll give you an example where they put in place resources very quickly during the pandemic to work with the regulator to expedite getting those individuals through the process. One of the things the primary issue we hear with internationally educated nurses is there's 3 main issues that cause them a problem to get into the workforce. Their immigration status, which sometimes impacts their ability to access programs, and it impacts career laddering opportunities because they're not necessarily seen as permanent residents yet. The second one is associated with the cost of going through the regulatory process, and not all individuals have the resources in order to pay the costs associated. In BC, as an example, we've seen an example where it can cost up to $15,000 for an internationally educated registered nurse to be registered in that province. And the third thing is long processing times. We've heard examples in provinces that it can take up to 3 years for an individual to make their way through that process. One of the things Ontario did was worked with the college to expedite that process, provided resources for them so that they had more people to assess individuals. And I think it's about matching the individual with their capabilities and helping them get registered into the right classification of nursing. And because what often happens is they find that they're not able to be registered in one and have to start through the whole process over again to be registered in another.
So it sounds like from what you're saying, it is possible with more resources to license more foreign graduates. And can you tell me in Ontario how many extra nurses were licensed as a result of this expedited process? Approximately.
I can't give you the number off the top of my head, but I can certainly try and get you a more clear number.
Yeah, that would be great. The other thing, is it true that nurses also have to be licensed province by province? And I know because my wife went to nursing school in the Philippines that her classmates, some were able to practice in Alberta, some were able to practice in California, and yet others couldn't get licensed in Ontario. Does this make any sense? Is Ontario's quality of nursing that much higher than California's in Alberta? I don't think so. Now, what about the possibility of national requirements for licensure in nursing? We've heard it from the medical profession. Have you considered it for nursing?
Yes, we have. I would say that the medical profession is further ahead on this matter than nurses are. We're advocating for a national nursing identifier that a nurse would have an identification number that would follow them through their whole career across the country. That is not the case now. It certainly causes much more of a challenge when you're talking about interprovincial mobility. We saw that in the pandemic. It was a huge issue for the Canadian Armed Forces when they were trying to move some of their resources between provinces. And if their resources are registered in Nova Scotia, as an example, and they need them in Quebec, they ran into issues with having to have interim processes to get them registered. There are mechanisms, or there could be mechanisms, that could make that interjurisdictional mobility much easier, and a unique identifier that's national would certainly get us closer.
Thank you, Mr. Guest and Dr. Pawlowski. Next, Mr. Barrett, please, for 5 minutes.
Thanks very much, Chair. Thanks to all the witnesses today. I'll take the opportunity to thank our nurses as well on the occasion of a week of recognition for all of their hard work. So I've had the opportunity to speak to some of you in meetings before. We've had you at the committee before, and I just wonder at what point the perfect becomes the enemy of the necessary, not even the good, just what we need to have happen so that we don't have more people running for the exits in the healthcare profession. And a couple of examples, and I've raised some of them with you before, but we have virtual medicine apps, telemedicine apps that are available where you can talk to a nurse practitioner and get a script instead of going to a doctor. We have electronic health records. So in the Canadian Forces, for example, it didn't matter which base or which physician's assistant I was talking to. They punched in my service number, up came my record. And I appreciate that when we're talking about people's medical information, that we have to be extremely careful. The highest sensitivity has to be paid to that. But do we not find ourselves where there are solutions out there that we could use? And it's just, is this a question of intergovernmental cooperation? And so with that framing in mind, I guess I would just ask, what are some things that could be done right now that would address some of even the low-hanging fruit? Because I feel like we have a lot of very big problems, and I just are there any short strokes that we can take to solve those as a country altogether?
Thank you for the question. I'll take a first stab at this. I would say certainly in the short term, something that could be addressed is what we're proposing, the Primary Care Integration Fund, as an incentive for provinces and practices to move to team-based care. We know how to do team-based care. We have a model of it. As Dr. Lemire mentioned, it's been out for quite a while now, and we just need to move to those models. That would be an immediate improvement. To the 2 points you raised, certainly a single source or integrated EMRs, I'm unaware of that crossing provincial boundaries, but even within provinces, that doesn't exist that I'm aware of essentially anywhere in the country. And to your other point on virtual care, we'd be the first ones to say virtual care is here to stay. It certainly enabled care early in the pandemic where we couldn't provide care safely elsewhere. And that technology will be essential into the future for geographic disparities, for efficiency purposes, patients not waiting in waiting rooms. There's concerns around equity, so we don't want to replace a family physician in a rural community with just virtual care. That's not fair to them. And virtual care can't replace everything in primary care and family medicine. And the other point I would emphasize is that all family physicians, I think, want to work with virtual care, but it should be integrated into longitudinal family practice. All Canadians deserve to see a family physician and their team over time, and that could be through technology solutions or it could be in person.
How much time do I have, Chair? 1 minute. If anyone else wants to contribute an answer in that 1 minute.
I'd be happy to. I would also like to add what Dr. Bouchard talked about. There is an ability to do more integration of the integrated or the electronic health records that we have. We have spent millions and millions of dollars across the country implementing systems that were not built with standardization that could speak to each other. They are capable of doing it, as technology evolves. We continue to add more of them and make the issue worse. Where I think if there was a requirement that all new systems had to be integrated, where Alberta, as an example, is the entire province is moving all of their hospitals onto a single system. We're seeing similar things across the country. I've seen examples in Ontario where an individual gets discharged from a hospital, transferred to a hospital 15 minutes down the road, and the entire chart needs to be printed off and sent with the patient in paper and then re-entered again into the system in the hospital adjacent to it because they aren't integrated. There is an ability to do that. It will be costly, but it would take some will to make happen.
Thank you, Mr. Guest. Mr.
Thanks for the
Barrett?
answers.
Okay, Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. My question is to Dr. Smart. Dr. Smart, you said need to improve virtual data. Yes, data is an area of concern in terms of well-managed health human resources too. And Pan-Canadian Health Data Strategy this is something we think to improving the system, good data, informed decision-making, and measured progress. So do you have any specific recommendation about how we can improve data collection, especially to the rural communities as well?
Well, I think to add on to what we've already heard when we've been talking about data today, I think it's really important that it is standardized and that you're using it for the right reasons, right? What we really want to see is a data-driven outcome-based system so that we're using the data to make sure that we're accountable for the investments we're making in healthcare and to make sure that it's driving the outcomes we want to see in our system. So I think if we design it from that lens, we can then use the data to be monitoring what we're doing, how close we're getting to the outcomes that we want to be seeing, and also to give feedback to the providers in the system about the care that they're giving to patients. So there's many ways using data effectively could improve the quality of care and accountability in the system. I think what's going to be critical and why we feel that this needs to be a pan-Canadian approach is to allow for that standardization across the country and to make sure that we're creating those basic standards across the country so that we're all moving in the same direction. And I think that's true from the patient data side. From the human health resource planning side, I think the data is going to be clear, needed so that we can actually know what we're trying to do. And I think like what you've heard today, some of why it's hard to answer some of the very specific questions about things, like how many nurses, how many doctors, where exactly, is because we don't know. And the other problem is sometimes we're not counting the right things. We could probably tell you how many people are licensed as a family doctor in Canada, but how many of those physicians are actually providing primary care in a rostered or longitudinal manner may be more difficult to do. And that's why things like saying, we need X number of more people is challenging, because if you add 1,000 family doctors to a province, but none of them actually take on a patient panel, it's not solving the problem of access to primary care. So I think we need to be really clear about what we're trying to collect with the data. We need to make sure that it's linked to the outcomes that we're wanting in our system, and that the whole point of it is accountability, because we know that investments in the Canadian healthcare system are a very significant use of our tax dollars.
Thank you, Dr. Smart. To My questions to all the witnesses. We heard need for more resources for administrative staff to remove healthcare professionals from the paperwork process. So what improvement can be made to this process and how impactful these improvement can be? So what should we do so healthcare professionals don't need to do the paperwork when the doctors need to know that what has to be placed in there? So what is the process we can be so it's a tangible outcome can come?
I can take a stab at this. I think what we have suggested is that an option for the federal government is to provide resources to the provinces and territories to be able to add additional capacity into the system so that they have individuals that can do some of those tasks to free up physicians and nurses to do the tasks that they can only do. That's some of what we have suggested. It's a matter of needing additional resources to put those workers in place.
Challenge is that we have different systems that are not talking to one another as we speak right now. And so the solutions, I think, would need to be adapted to regions and locales in order to be able to be effective. I don't think there's one size fits all here. I'm trying to think to myself in terms of my own practice. When I had one using my EMRs, could actually a clerk do the ordering of some of the things I was doing? And the way the system was working, I think it might be quite difficult. And so there really is a need to have conversations at the regional level to see what could be farmed out to individual to provide that clerical help, as Mr. Guest has mentioned. So it's difficult to have a one solution unless Dr. Smart or Dr. Bouchard are aware of any one solution to help with this.
No, I would agree. I don't think there's a single solution, but I think some of the things we've heard. The other thing that we've seen be effective in some settings is having access to a scribe. So it's someone who's actually working with you, documenting for you, filling out the forms as you go and supporting that work. And that can be a way to really bring down that administrative burden as well. So I think there's lots of different strategies. I think it would probably be a matter of picking 2 or 3 and trying them and seeing how they work, and then looking at what could be scaled into different environments.
Okay, thank you, Dr. Smart. Monsieur Garon pour 2 minutes et demie.
Mr. Garon, 2.5 minutes. Thank you very much. I have a question for Dr. Lemire. I'd just like to welcome you. I haven't had an opportunity to ask you a question yet. You were referring to a federal fund that would be a targeted fund and that the provinces could apply for, and the purpose of it would be to really focus on the models that would be developed by the various provinces, the ones that would be most promising and most effective. You mentioned family medicine, le groupe de médecine familiale in Quebec. I like this model. I'm a patient in one of these models. I'd like to make sure I've understood correctly. So Quebec has some constraints in terms of funding issues, but that's a successful model. The federal government has a fund. It is subject to conditions, and because the Quebec has developed this system, now Quebec would have to turn to the federal government to ensure that its own model that it developed would have to then be funded through the federal government. That is one example. That is one example of how the fund could be used. I think in Quebec, about 70% of family physicians have the option to join one of these family medicine groups. You may know the statistics better than I do, actually. Based on what I'm hearing, this is a promising model. There are opportunities for improvement of the model, but the fund would mean that it could there'd be a possibility. There'd be the option to examine what you're currently doing, the option to improve the system that you currently have, and it would also mean more family physicians could work in teams using this particular model, which would be a model which could keep being improved. I only have a few seconds left, Dr. Lemire. What do you think of the idea that within a well-funded system where the federal government transfers more to the provinces, if you would have 10 provinces and Quebec would be in a position to develop better models, and other well-funded provinces could naturally, of course, gain inspiration from these other models that have been well designed in other provinces. What do you think of better funding provinces in order for these provinces to take inspiration from one another? Answer, I think that's what we're trying to promote. Perhaps you're thinking of another model? I'm not sure I understand your question. Okay, I'm thinking of substantially increasing unconditional healthcare transfers, which would mean the provinces could develop these kinds of models and gain inspiration from one another. Perhaps the lack of innovation may be due to the fact that our provinces are short of funds, and there's been a drop from 35 to 21% of system costs in health transfers. That's it for your time, sir. An answer quickly. We think it's important to have dedicated funding for reforms and improvements. It doesn't mean that you couldn't have a fund that would have more latitude, but this idea of having a specific dedicated fund would be positive. Thank you.
Last person to pose questions for today's session is Mr. Davies for 2.5 minutes.
Thank you. Well, picking up on Mr. Garron's question, we've heard repeatedly that we need a health funding summit involving the provincial and territorial premiers as well as the Prime Minister to discuss the Canada Health Transfer. It strikes me that what you're talking about here are some very targeted ideas about how we could put, I think it's at least $2.25 billion into the fund to address the healthcare shortage. Just by a show of hands, how many of you would like to see a health funding summit for prioritizing initiatives necessary for resolving Canada's health workforce crisis? Do we need that? Okay. There are people in the room putting their hands up. Thank you. Second, say that
everybody put their hand up so that it's on the record.
Oh, so, sorry, what's that?
Say that everybody put their hand up.
Everybody put their hand up for the record. Thanks. In terms of national licensure, I'm going to pick up what my colleague Dr. Pawlowski said. There may be different provincial standards for various things, but I can't believe that the qualifications of a doctor or a nurse in New Brunswick deviate from a doctor or nurse in Manitoba or British Columbia. When you are raising this, is anybody raising jurisdictional issues here? Is any province, in your view, are they holding up their jurisdiction to prevent this concept of a national licensing, or are you hearing positive results from the provincial colleagues that you talk to?
I can comment on that. You are right. If you are a Canadian-trained, Canadian-credentialed physician, you are eligible for licensure in any province or territory. So it's not an issue that you won't be licensed. You just have to go through the steps to obtain the license. The standards, like the requirements for that, are the same. That's not always necessarily true if you're internationally trained, but if you're Canadian trained. I think we're starting to see some shift in terms of people's willingness. I think, again, there's the regulatory bodies all have their way of doing things, and I think everyone naturally thinks their way of doing things may be the best or the safest. I think that we see that protectionism in many aspects of how people work. But I do think the pandemic has shifted that. I think people are starting to see now the need for more cooperation, the need to be able to leverage virtual care, just the crisis that the health workforce is in, and the need to sort of back away from some of these more protectionist ideas to more of a collaborative lens. It doesn't mean there would be no role for the provincial regulatory bodies. It would be more about creating, opportunities to collaborate and reimagine this somewhat. There would still be responsibility for them and a role for them to play. But I think we probably are closer to that reality than we were pre-pandemic. I think if you'd asked people the same question 3 years ago, they might have said, ooh, we were, really far off from that ever happening. And I think we're closer now. And I think it's just going to need that kind of final push to get it over the finish line. But in my view, if we were able to pivot an entire country to virtual care essentially within 48 hours, I think we can achieve this as well.
Thank you, Dr. Smart, and thank you, Mr. Davies. That's a very optimistic note on which to end. And I'd also like to share with you, witnesses, that this is probably the last panel of this study. So I expect that unless there's other suggestions for further witnesses, we're probably going to be issuing drafting instructions fairly soon. So thank you so much for helping us through this journey. With your patience and with your very thorough answers, greatly appreciated. And thank you for your work on the roadmap. I do expect it to be a very important element of the report that we bring forward. Colleagues, just a couple of things before we wrap. Wednesday's meeting will be a do-over of the meeting that was canceled last Wednesday. So same witnesses and ideally committee business at the end to talk about what we're going to do next. And we have the Finnish delegation coming in on this Wednesday at noon. So we encourage you to be there. Is it the will of the committee to adjourn the meeting? Yes. We're adjourned.